Hello everyone, I'm Dr. Neha, your educator and mentor for community medicine on Unacademy platform. So let us discuss another set of Super 5 PSM MCQs. Before that, I want to tell you that Unacademy has come up with this amazing opportunity where we are giving you there is a wonderful batch which is starting NEET PG 2023 to help you in your NEET PG 2023 preparation. All Educator Ultimate Revision batch, in which test and discussions will be covered, PYQ, previous year questions, image based questions. This is starting on September 30th and the duration is 6 months. And currently, Unacademy is running an offer where you can get 20% off on your Plus as well as Iconic subscription. Okay, so this offer is only valid till 30th of September. So now is the opportunity and the time when you can avail this offer. You can get this course for 6 months at 15,300. You can use code NPG10 or you can use code PSM10 and avail 20% off. Okay? So this is one batch which is starting a NEET PG 2023 All Educator Ultimate Revision batch. Also, there's a batch which has started for FMG revision. It is last mile revision batch, well structured batch with all 19 subjects coverage in 3 months, interactive classes with your educators, PDF notes, recorded sessions also available, and practice with more than 18,000 new question bank. Okay, so as an improved curated question bank which Unacademy has launched. This started on 16th September. You can still, it's not yet too late. You can still avail it. Use code PSM10 and get a 20% off on your subscription. Now, the question bank which is available for our NEET PG learners on Unacademy is Question Bank 2.2, which is completely revised and it is completely improvised. Okay, new set of clinically integrated questions and a lot more you will find on Question Bank 2.2. So this is the offer. Celebrate your love for learning. Enjoy 20% off on NEET PG preparation. This is valid till 30th September. Just use the code PSM10 and get 20% off. Okay, for 6 months, 12 months, whichever how many months you decide. Okay, so now is the opportunity. Don't miss out on it. Okay, let us go to the first question now. All are true about growth charts except it is a tool for educating mothers. Do you think growth chart is a tool for educating mothers? Absolutely true. Growth chart is actually a tool for the health workers and the mothers. Okay. Position of dots is more important than the directions. No, direction of the dots. Abhi, when we will, discuss growth chart in a little detail, you will realize that it's not position of the dot. Okay. Between top two lines, it shows road to health or zone of normality. Yes, between the standard line and the one below it, which falls at -2 standard deviation, it is road to health or zone of normality. I'll be discussing growth chart in just a while. Lowermost line corresponds to children below 2 percentile. No, this is false. It corresponds to children below -3. Okay, -3 SD. Type of growth charts used by Anganwadi workers for growth monitoring is based on multi-centric growth reference study. This is multi-centric growth reference, MGRS standards. Absolutely true. Okay, so first we'll discuss growth chart and come back to this again. Okay, so let us talk about WHO growth charts. Okay, now WHO growth charts are based on multi-centric growth reference standards. Okay, this was a study which was conducted in 6 countries and India was also a part of it. So in WHO growth chart, we are again plotting age and weight, and in this there are two lines like this. Okay, the first one over here of course is the standard, and this first line, this is known as URC, meaning upper reference curve, and URC corresponds to uniformly 50th percentile for boys. Okay, and this one over here is the lower reference curve, and this lower reference curve corresponds to third percentile for girls. Okay, and if you look at this chart, there is a zone, this one, this is green color. Okay, this denotes road to health, and below this lower reference curve is an area of mild to moderate to severe malnutrition. Okay, so in WHO growth chart, we have an upper reference curve corresponding to 50th percentile for boys and a lower reference curve corresponding to 3rd percentile for girls. Okay, now this growth chart has been adopted by the ICDS or the ICDS growth charts are based on the growth charts which is used for monitoring of growth in Anganwadi centers are based on WHO growth charts. Now, how does our ICDS growth charts look like? If you've seen an ICDS growth chart, this is going to have three lines like this, okay? All right. Again, this is the URC, upper reference curve. This is the standard, or you could say zero. This is the lower reference curve. This corresponds to minus 2 SD. And this third line is minus 3 SD. So, if a child lies between standard, or you could say 0 and minus 2 SD, the child falls in which zone? Green zone. So, this is the green zone. Green zone means road to health. Okay, normal growth of the child is happening. Then, if the child falls between minus 2 standard deviations to minus 3 standard deviation. This is the yellow zone, and yellow zone indicates what? Mild to moderate malnutrition. Okay, so this is yellow zone is what? Mild to moderate malnutrition. And if the child falls below minus 3 SD, this is the red zone, which is severe malnutrition. Okay, so if the child falls below less than minus 3 SD, this is the red zone. So this indicates what? Severe malnutrition. Okay, so these are the three zonings that we need to remember. Green, nothing has to be done, counseling, okay, a small that whatever the mother is doing is correct. Yellow, the child can be shown to a medical officer at a PHC and sent back home. Home management, okay, so yellow is home management, okay, yellow is home management, okay, and return for follow up in 3 days. All right, return for follow up in how many days? Return for follow up in 3 days. Okay, you have to advise the mother about the danger signs and you have to tell her that she should come in 3 days. And red is severe malnutrition, immediately refer to CHC and higher centers where you are going to have at least a pediatrician in possession. Okay, so this is the WHO growth chart, or sorry, ICDS growth chart, which is based on WHO standards. Okay, and WHO growth charts were adopted from multicentric growth reference study. Green zone between 0 and minus 2, road to health. Minus 2, minus 3 is mild to moderate malnutrition, and below minus 3 is severe malnutrition. So the child has to be referred. So look at this. What are the uses of growth chart? It's a tool for educating mothers, for monitoring of growth. All right, position of dots. Now, if a child falls here for the first time, this is not important. But later, tracking his direction by plotting the dots, that is more important. Okay? Between two lines, it shows road to health. Yes, lowermost line corresponds to below 2 percentile. No, below minus 3 SD. And the type of growth charts used by Anganwadi workers for growth monitoring is based on multicentric growth reference study. So all are true except B and D. Okay, let's go to the next one now. So in NRHM and ICDS, Government of India, Government of India has adopted the WHO Child Growth Standards 2006, also known as Multicentric Growth Reference Study Standards. Okay. True about polio vaccination are all except supplementary immunization rounds are done with trivalent OPV. Is it? No, this is wrong, right? This is false because now whether it's routine immunization or it is your supplementary immunization, right? Whether it's routine or supplementary immunization, what are we using? Are we using trivalent OPVs? No. Now we are using bivalent OPV, whether it is routine immunization or supplementary immunization. Because we had proposed the concept of switch, if you remember, there was a concept of switch which was proposed in April 2016, where a switch from trivalent OPV was done to bivalent OPV. In trivalent OPV, we used to have wild poliovirus strain 1, 2, and 3. Right? In bivalent, we removed which component? In bivalent OPV, we removed the wild poliovirus type 2. So only 1 and 3 were left. Right? We removed 2. Why we removed 2? Because wild poliovirus type 2 was responsible for circulatory, or I could say CVDPV, which is circulatory vaccine derived poliovirus. Now, circulatory vaccine derived poliovirus, D for dangerous. Okay, this was dangerous and it was causing what? It was causing outbreaks. Okay, it would cause outbreaks. Vaccine derived poliovirus, paralysis among the recipients. And it was seen that wild poliovirus type 2 was already eradicated in September 2015. Okay, so the government thought that why are we still retaining type 2 component in the vaccine when it can lead to something known as circulatory vaccine derived poliovirus, which is dangerous, can cause outbreaks. And when type 2 has been eradicated, let us remove it. So we proposed a switch from trivalent OPV to bivalent OPV. Now, even wild poliovirus type 3 has been eradicated in October 2019. And wild poliovirus type 3 leads to VAPP. What is this? This is vaccine associated paralytic polio, but remember that does not cause outbreaks. Okay, it does not cause what? It does not cause outbreaks, so we did not remove it from the bivalent OPV. It's not as dangerous. All right, so switch was April 2016, and also there was a day which was celebrated as National Validation Day. And what was special about this day? On this day, India was declared free of, okay? Yeah, India was declared free of trivalent OPV. Nowhere in any healthcare center would this be present, trivalent OPV. May 2016, okay, it was declared free of trivalent OPV. So now whether it's routine immunization or supplementary, we use bivalent OPV. Confirmation of case of polio should be done within 90 days. Absolutely true. For AFP surveillance, guys, acute flaccid paralysis surveillance, we have to confirm a case of polio within 90 days. But you have to check for residual paralysis. Check for residual paralysis when in a case of AFP, you have to check for residual paralysis in 60 days, but confirm a case of polio within 90 days. Pulse polio doses are routine doses? No. Pulse polio doses are not routine doses. They are additional doses. That means irrespective of the previous immunization status, pulse polio, additional polio doses are given, 2 drops of polio are given to all children between 0 to 5 years of age. Oral polio vaccine provides intestinal immunity also. Yes, it's a live vaccine providing both humoral and intestinal. Salk contains two types of polio virus. What is K? K is killed. So killed is IPV. IPV contains two types? No. IPV contains killed form of all three types. Killed form of wild polio virus 1, wild polio virus 2, as well as wild polio virus 3. So this is also false. So these are the false statements. Okay. Oral polio vaccine is live. Now we just use bivalent OPV containing type 1 and type 3. Killed poliovirus Salk is containing the killed form of all the three varieties. Okay? Pulse polio, all these are routine doses. No, they are supplementary immunization round. 2 drops of polio is given to every child between 0 to 5 years, irrespective of the previous immunization status. AFP case may be confirm a case of polio within 90 days, check for residual paralysis in 60 days. Okay, so some of these points which national validation day is important. Okay. Average number of girls that would be born to a woman if she experiences the current fertility pattern throughout her reproductive span, assuming no mortality. What is this? So, if you remember, girls, G, gross. No mortality, gross reproduction rate. We've done this before also, right? So here you have to remember a few things. These are all fertility indicators. The first one over here is total fertility rate. Okay, what is total fertility rate? So total fertility rate is the total or the average number of children, total, or you could also say average number of children any reproductive age couple will have throughout their reproductive lifespan. Any reproductive age couple has throughout their reproductive lifespan. Okay, so it is the total number of children. Okay, so TFR is total number, so it is an indicator of complete family size. Okay, the total number of children a woman will have throughout her reproductive lifespan of 15 to 49 years. Total marital fertility rate will be total number of children a married woman will have throughout her reproductive lifespan. Now, out of those total children, how many are girls? That is GRR, gross reproduction rate. Okay, so gross reproduction rate is total number of girls a reproductive age woman will have. Okay, total number of girls a reproductive age couple will have. Okay, it's the total number of girls any reproductive age couple is going to. Okay, so gross reproduction rate is the total number of girls. TFR, everybody, is the total girls, the total children. Okay, out of these children, how many are girls is gross reproduction rate. Okay, but we have to assume no mortality over here. Okay, so assuming no mortality. All right, here we don't consider mortality. So what is gross reproduction rate? Total number of girls any reproductive age couple will have, assuming no mortality. Okay? And what is the third one? Net reproduction rate. Net reproduction rate is total number of girls who are going to stay alive. Total number of girls who are going to stay alive. Okay? So total number of girls reproductive age couple will have. Okay? Reproductive age couple will have, considering, all right, reproductive age couple will have, considering the current mortality. All right, considering the current mortality. So over here, if there are altogether 4 children, how many are girls? Suppose 2. By law of probability, there's going to be 2 girls. And how many will remain alive considering mortality pattern? That will be net reproduction rate. Okay, most sensitive indicator of family planning achievement. Everybody remember this. Most sensitive indicator, okay? Most sensitive indicator of family planning achievement, all right, is what is net reproduction rate, because it takes into account mortality, all right? What is the next point you should remember? For any population to stabilize, the TFR of a country should become 2.1. Okay, and it will become 2.1 when net reproduction rate is equal to 1, which is replacement level of fertility. And this will only become equal to 1 when couple protection rate, all right, is more than 60%. Okay, the couples practicing family planning is more than 60%. For India now, the TFR is already 2. Okay, and couple protection rate has already reached 66.7%. More of this we will be discussing, but as of now, remember one thing: total number of children is TFR, girls is gross reproduction, considering the current mortality is net reproduction. Okay, let's go to the next one: denominator insensitivity. So, what is sensitivity? If you remember, sensitivity is ability of a screening test, okay, ability of a screening test to identify all those who have the disease, right? So if you remember the formula, suppose disease, yes, no. Screening test, yes, no. This is A, B, C, D. What is A? Those who have the disease, screening test also positive, true positive. What is B? Disease not present, screening test positive, false positive. C, disease present, screening test negative, false negative. And D, disease not present, screening test negative, true negative. And what is sensitivity? Ability of a screening test to identify correctly all those who have the disease. So gold standard will identify all those who have the disease, which is TP plus FN. And screening test will identify it in TP. So what is this denominator? Is it all those who have the disease? Is it all those who do not have the disease? Is it all those who show positive result or show negative result? So what is this? It is all those people who total number of diseased people. Okay, that is very important. Similarly, specificity is all those who do not have the disease. So when I talk about specificity, how many do not have the disease? TN plus FP. And out of them, screening test has identified in TN. So total number of healthy people, denominator is specificity. Different ways of asking the same question. PPV is equal to, out of all those who've been tested positive by a screening test, how many actually have the disease? So TP plus FP have been tested positive. Out of them, how many actually have the disease? NPV is, out of all those who've been tested negative by a screening test, how many actually do not have the disease? Okay? Okay. Now, last question: if the prevalence of a disease in a locality increases, positive predictive value, this is very easy. It's a direct relation based question. If prevalence increases, PPV increases. Okay, if prevalence increases, NPV decreases. So, PPV is directly proportional to prevalence, and NPV, everybody, is indirectly proportional to prevalence. So, if prevalence increases, PPV increases. Okay? So that's a quick look at 5 MCQs. Before I end, please remember, at present, Unacademy is giving out this amazing offer where you can use a code PSM10 and get, or you can also use the code PSM live and get 20% off on your Unacademy subscription. All right, and remember the batches: there's an all educator ultimate revision batch which has started. Also, there's a FMG December race last mile revision batch. Plus, we have an updated question bank to help you in your practice. Thank you so much. Have a very good day. Keep studying and don't lose hope. Bye bye.